ऊपर दिखाओ.
Yeah, very well. Good afternoon, Dr. Hiramat.
दिखाना.
Yeah.
Yeah, Dr. Manjunath,
Yeah,
Hiramat
we are
here.
hearing you.
Yeah, I think so. Let's see कितना होगा.
With me, we have
Yeah.
Dr. Makhre, Dr.
Yeah.
Shokan, Dr.
Get a
Nishit
picture.
Choksi, and Samir Dani.
And I think after this,
So we are ready for you. Your story.
I asked
Okay.
Dr. Manjunath to finish 2 cases.
Yeah, good afternoon to all of you.
Have half an hour, 20
Will you
minutes.
be a
first.
little louder?
I think what we'll do.
See, little different from, little different from the morning. We are moving from coronary to valve here. This is a 37-year-old lady of rheumatic mitral stenosis. You can see here she is in atrial fibrillation and left atrial appendage clot type 1A as per based on our classification. She was anticoagulated for 3 months. So she is in function class 3, atrial fibrillation, and heart rate on the table is about 120. Blood pressure is 120 by 80. And we'll show the other pictures. This is next atrial fibrillation. This is typical X-ray of rheumatic mitral stenosis, pulmonary hypertension. And you can see here the parasternal lang axis shows dooming of the mitral valve and bit of calcium on the posterior mitral leaflet. Then in the left lower panel you can see the short axis of the mitral valve that orifice is less than 1. And there is TR. And there is pulmonary artery hypertension is around 70. Pulmonary artery systolic pressure is 70. If you look at the short axis of the mitral valve, the anterolateral commissure is free from calcium, while the posteromedial there is some amount of calcium. This is very, very important because if both the commissures are calcified, then there is always a risk of leaflet tear. So at least if one of the commissure is free from calcium, you can still have a balloon mitral valvuloplasty. This is a transesophageal echo for you. You can see a clot confined to the LA appendage, protruding a little bit into the body. And of course, there is spontaneous echo contrast. So since the clot is confined to the appendage body and anticoagulated for about 3 months, we are going ahead with the balloon mitral valvuloplasty because our hardwares will not be into the appendage at all, and the clot is also organized. Yeah, this is the story of this patient, Dr. Hiramat.
Yeah, I'm surprised they kept half hour for you, Dr. Manjunath. I mean, I'm sure you'll finish in a few minutes. That's
No. Okay. So only thing, we have to use a 3-2 wire for threading the Mullin sheath because the Mullin sheath doesn't go over 3-5 because most of our labs do have only 3-5. So if you, unless you have a 3-2 wire, Mullin sheath doesn't slide. So you can always see that this sparks, you can maneuver so that it is in the left innominate vein, so that when you are coming down, it gets an angle onto the atrial septum. This patient actually was on anticoagulation, stopped 5 days back. INR yesterday was 1.3.
Was she anticoagulated for a length of time earlier or no?
Yeah, she was anticoagulated for about 3 months. The whole objective of anticoagulation is let the clot become more adherent and more these things. So I'm LV 40. So I'm just one space below in AP view, then I'm going to LV 40.
Low function.
So LV 40 we have to pick up a point between pigtail anteriorly, vertebral column posteriorly. So you can see I'm just injecting, we are in the left atrium now. So now I will just advance the Mullin sheath, keep over the broken barrel needle. because you should not advance with the needle projecting beyond the Mullen sheath because there is always a chance of perforation. So can you show the pressure? We are into the left atrium actually. Now we are in LA. So let me take a simultaneous LV as well as LA pressure. Can we show that? So there is a big diastolic gradient, okay? LA pressure is 53/24, mean of 38.
Yeah, we can see that very well.
So so we'll go with the spring guidewire now. Yeah. I always keep pigtail in descending aorta. Any flushes and all, you can always do it. See now, to know whether you have gone to the softest portion of the septum, just the Mullen sheath itself you can advance and see. Yes, Mullen sheath is going smoothly. So probably it has gone through the softest portion of the AS. Many people say I always puncture at fossa ovalis, which I don't believe. Many times you are across fossa ovalis, sometimes it's above fossa ovalis, sometimes it's below fossa ovalis.
You are a very honest interventionist, Manjunath.
So this is 35, I mean our height is 165. So we are going to, because as per the formula we have to take 25 balloon, but I will downsize by 2. See, many a time rather than doing multiple runs of the septal dilator, you can just dilate, keep it for 30 seconds, it stretches the septum nicely. Because septal puncture is not just for balloon mitral valvoplasty, we have other procedures, LA appendage closure, left heart catheterization, mitral clip device, so many things.
So what are going to be the special steps?
Another important thing is you have to always keep an eye on the
Special steps to avoid the clot.
you have to keep an eye always on the left. Yeah, I think since it is an appendage clot, I am just doing routinely. Otherwise, if the clot were to be in the roof of the thing, we would have done over the wire technique. That is where we introduce the spring guide wire instead of LA into the LV itself. See here, when once 2/3 of the stretched balloon crosses this thing, you release this balloon stretching tube so that it doesn't get into that zone. Yeah. Always, I never flush into the left atrium. Always we keep aspirating because
what about the heparin? Have you already given the heparin?
So we have to come and look for this.
Dr. Manjunath?
Heparin 3000 units we have given. Yeah, 3000 units given. Before septal puncture only I had given. Because sometimes you can give after septal puncture, sometimes. So you can always watch for this bobbing movement. that means you are on top of the mitral valve.
Shaping. Yeah.
So one thing, you always make sure that the balloon reaches the apex, otherwise it can get stuck in the subalveolar apparatus. 50%? Yeah. Oh, sir, okay. 1 second. Yeah. $50?
ಸ್ವಲ್ಪ ಬರ್ಬೇಕಾ?
Yeah, come on. Very okay.
Full breakfast.
So we'll just check with the gradient as well as the mitral valve area.
There is one systemic.
So because you're slightly undersized, you could go full on the inflation, right?
Yeah. Elena?
Yeah, ele.
Huh?
ele.
Okay. We'll superimpose. I think always you should inflate, Dr. Iramet, at a high pressure zone. So, see here our required balloon diameter was 24. So I inflated at, I have taken a 26 balloon. So if you inflate at 24 in a 26 balloon, you generate a great pressure. Suppose if you take 28 balloon and inflate at 24, then you will not generate that great pressure. So we have to inflate balloon at a high pressure zone. So if your required diameter is 24, you take 26 balloon, or if your required diameter is 22, you take 24 balloon.
So is there something like soft dilatation, like if there is an
Otherwise,
associated mitral regurg, people underdo the dilatation? Is that acceptable or no?
No, if there is a calcium or if there is MR, you can downsize the balloon by 2 millimeters. So it's fine.
LA pressure is still high, 25.
I think with a heart rate of 144, a gradient of around almost diastole, it is touching.
ತೋರಿಸ್ಬಿಡಿದು
Just to, you can show the
pressure.
Yeah. You'll have an echo?
So
Yeah.
you can show that.
No, it's coming. Yeah, it's a wide jet actually. In fact, LA pressure has mean has dropped from 35 to 17. So you can see here a wide jet. Because of atrial fibrillation, fast heart rate, so you can go on the short axis and show. Yeah, I think you can zoom that.
ಬೇಡ ಬಿಡಿ ಪ್ರೆಷರ್ ಬೇಡ.
Yeah, freeze.
ಪ್ರೆಷರ್ ಬದಲಿಗೆ ಎಕೋ ಕೊಡಿ.
Echo.
Instead
Show
of
the echo,
pressure, show
please.
the echo. Yeah. Running.
Yeah, you can see here both anterolateral as well as posterior medial commissure is well split.
Yeah, we can see that.
And
on
there
the
is no
echo.
MR. Hello?
Yeah,
I
we
think
can see
lost
it well
the
on the echo.
Contact. It's fine. It is. Hello?
Yeah, we can see it very well. Well, how much is the area now?
He's asking why they are giving Manjunath 30 minutes. For you, 5 minutes is enough. ಅಲ್ಲ
So
ಇದಾಯ್ತಲ್ಲ gradient test.
So Dr. Manjunath, you're 5 minutes ahead of time. Nishit, any comments from you? Interesting that you are here.
I don't do much of
Hello?
valvuloplasty.
What is happening with the audio?
Done
I mean,
couple
audio
mitral
visual.
valve replacement,
ಏನು ಬರ್ತಾ
now.
ಇಲ್ವಲ್ಲ?
and they worked out very well. We use the
14
sapien
Hello?
aortic valve
Hello?
in mitral position.
Yeah,
Hello?
Manjunath, we can hear you.
ಸೌಂಡ್ ಬರ್ತದೆ.
Short
Back in
access.
US, we don't get
ಏನು ಹೋಗ್ತಾ ಇಲ್ಲ ಅನ್ಸುತ್ತೆ.
too much of these mitral valves, but every now and then there is
Zoom ಮಾಡಿ.
prosthetic mitral valve stenosis.
ಯಾಕೆಂದ್ರೆ heart rate fast ಇದೆಯಲ್ಲ.
So where do you think the septal puncture technique would be useful for you in
You
US?
take that.
Pardon?
Septal puncture techniques,
Both are split.
where it will be useful for you in United
This one it
States?
should be. Hello?
For this mitral
And what
valves,
is happening?
for atrial appendage occluders, they're very important.
All right, Mr. Padmanabh, can we switch to Dr. Khanna's?
Yeah. ಅದು ಆಗೋಯ್ತು ನಮ್ದು.
Mitral clips are
ಆಗೋಯ್ತು.
very,
ಬಿಡಿ.
mitral
Hello?
valve
ಬೇಕಾಗಿಲ್ಲ, both
is very
commissions
important to
split.
do.
Yeah, yeah. So you can
Posterior,
see here,
inferior,
uh,
which
actually you can see here the short axis of the mitral valve. Both the commissures are split. See,
ನೀವು ಮಾತಾಡೋದು ಕೇಳಿಸ್ತಾ ಇದೆಯಂತೆ. ಯು ಜಸ್ಟ್ ಕೀಪ್ ಟಾಕಿಂಗ್ ಅನ್ಸುತ್ತೆ.
yeah. So both the commissures are split, and I think end diastolic. Yeah. I think I don't want to dilate anything further here because we have achieved a good area is around 1.8, and LA pressure has dropped, and end diastolic gradient is hardly 2 to 3. See, when we are removing the balloon from the left atrium to right atrium, normally you have to put back the spring guide wire and this thing. If it comes smoothly, it is fine. Here it is coming smoothly, that's okay. And let me check the RV pressure rather than going for an exchange with the NIH catheter, endole catheter. Let me check the RV pressure with the mitral balloon itself. So, because otherwise it takes lot of other exchange and all. Dr. Iramet,
Yeah, we
Hello?
are watching that, yes. So that's
you are with
RV.
us?
Yeah, this is
Yeah.
RV, right?
Baseline
See RV pressure before the procedure was 75 systolic, and now it's around 59, 55, 59.
Can you show the hemodynamic? Yeah.
So this is one. I think with the same mitral balloon, you can check the RV pressure, which indirectly always gives pulmonary artery systolic pressure. Otherwise, you have to exchange for this again spring guide wire. Then you have to introduce, endole or those catheters. So this will shorten the fluoroscopic time. So definitely, PA pressure has dropped from 75 to 50. 50 now.
ಬರ್ತಾ ಇದೆ. ಎಲ್ಲಿದೆ? ಬೇಸ್ಲೈನ್ ಟಚ್ ಆಗ್ತಿಲ್ಲ.
Yeah. See, when we are stretching the balloon, one point here, you have to keep the spring guide wire loop well in the, at least 2 loops should be there in the right atrium, beyond this balloon tip. Yeah, have the loop, yeah, still. See, otherwise what happens, if only tip of the wire is projecting, then you try to stretch the balloon, that wire can get cut. So best is have 2 loops beyond the balloon, then you can lock and stretch the balloon and remove it. So I think this is for you. Any questions from the panel or?
ಆಡಿಯನ್ಸ್.
No, that was
Hello?
Dr. Manjunath, that was
Again
excellent case
disconnected.
demonstration. Actually, BMVs by and
Hello?
large nowadays are
ಫ್ಲೂರೋ ಮಾಡ್ತಾರೆ.
sort of not done by many people. So I think this was an excellent case, step by step, particularly with the electrode.
Anyway, procedure.
Okay, Dr. Manjunath, that was great. Thank you indeed.